Vera Donnenberg. It's United States, Pittsburgh, localized conditioning of pleural environment. Please, Vera.
Well, I too would like to thank Professor Stupitsin and Janosi for inviting me. I'm very honored to be part of this distinguished group of internationally known scientists. And as a matter of fact, I couldn't understand why I was included in the hematopoiesis and immunology session, because my interests are in pleural pathobiology. And I'm speculating that the reason is my love of science and my love of Hungarian salami. And actually, my love of Hungarian salami got me into a lot of trouble at the last meeting in Budapest, because I proceeded to buy two full 1 kilo sticks and attempted to bring them to United States. But as a scientist, I declared my purchases, and the US Department of Agriculture told me I am not allowed to bring this delicacy to United States. So at that point, I proceeded to stop, go back in the line, in the queue, and eat this salami. The problem is when you ingest over 1 kilo of Hungarian salami, you don't realize you're going to be thirsty, not just on the next flight, but for the next 2 days. So that taught me another lesson, and that is that many times it's better to make decisions with your head and your brain and not with your heart. Which button? So, as I alluded, I study malignant pleural effusions. Pleural effusions are a stage 4 disease, and it's an end-stage disease. And when the cancer infiltrates the pleura, the chest wall, and the lymph nodes, the thoracic lymph nodes, and this disrupts a fluid balance, and that's how we have a fluid accumulation. We can also have pleural effusions as a result of drug reaction or cardiac insufficiencies, and we actually study those as well because they provide very critical non-malignant environment control. As you imagine, patients experience significant apnea, and that limits their ability to perform daily tasks in otherwise very ambulatory patient population. In the US, when this happens, the treatment is basically palliative. Indwelling catheter, it's inserted, and patients drain themselves many times, sometimes 3 times a week at home. In the past, before the COVID pandemic, the patients would come and see us every 2 weeks or a month or so. But that's no longer the case. Pretty much patients have a visiting nurse or their caregiver, and they are drained at home. So today, we really have no effective treatments for this condition. And the survival is absolutely abysmal. You can see the survival curve. And we believe that it's the pleural environment that promotes what we call epithelial to mesenchymal transition, that leads to aggressive tumor behavior and suppression of anti-tumor immune responses. And I also want to mention that it doesn't matter what kind of cancer, it doesn't matter what was the primary, it doesn't matter what type or subtype, including hormonal receptor positive breast cancer. When this disease comes to patients' pleura, it is almost incurable. It is actually incurable. Now, this is what it looks like radiographically. This is what the drainage looks like. Many times we get a liter of fluid per side because effusions could be unilateral or bilateral. But most importantly, when you see, this is just a cytospin preparation, and the pointer doesn't seem to work, you can see the big tumor nest. You can also see shed mesothelium and you can sort of see the very small dots. Those are immune cells, mostly T cells, and of course there's a macrophage infiltration as well. So we've been studying these for the past 15 years, and I will show you why it's critical not just to target the tumor, but also to consider the local environment. And actually, my colleague Jean-Francois mentioned it at the end of his talk, that we need to be thinking, for us to eradicate cancer, we will have to be considering the environment and at least conditioning the environment. So we propagate anti-tumor immunity, and we keep anti-tumor immunity. What this slide shows is that when you look at epithelial to mesenchymal transition, this is a transition that epithelial cells make as early as during gastrulation. These cells detach, they become motile, and then they seed and they either make organs or they metastasize. And some of the markers we use and measure by multiparameter flow cytometry, or now by the temporal spatial multiplex imaging, MPEs, and that stands for malignant pleural effusion, are virtually all EMT. Again, very important because this shows the tumor heterogeneity in the state of the tumor. This heterogeneity is actually conditional, and we can drive these tumors either more mesenchymal or more epithelial. From the survival curve down, you can see that in primary, this is a non-small cell lung cancer, resectable lung cancer, subset of patient already expresses this phenotype, and of course the patients with this phenotype have absolutely abysmal survival. And we have shown this not just in lung cancer, but in esophageal and breast cancer. Now, what about macrophages? It's again another very, very prominent cell type that is present in the pleura, healthy or in effusate. And the top bar graphs actually compares the phenotype in adipose tissue-resident macrophages to macrophages isolated from benign effusions, that's shown in black, and in pink is breast cancer malignant pleural fluid resident macrophages. And what you can see, and we have published this, that these cells are very, very M2 pro-inflammatory wound healing like, but that histogram in this corner up there shows you that with little conditioning, 24 hours of TLR stimulation and interferon gamma, these cells can express CD86 and CD80, which is co-stimulation, which drives antigen presentation. Well, what about T cells? Obviously, I'm not originally from Pittsburgh, but I've been in Pittsburgh for almost 30 years. So I'm very fond to call pleural infiltrating T cells PITs, the acronym PIT. And you can see that, again, in the pleura, they are B cells, and they are quite plentiful. They are quite rare natural killer cells. And there's a very nice proportion of CD4 and CD8 T cells. And the CD4 T cells certainly predominate in the pleura. Now, what do these cells look like? What do the T cells do when you take them out? When we take these pleural T cells, we keep them in that pleural environment, and we stimulate them, and we measure effector cytokines, IL-2, IL-10, interferon gamma, and TNF-alpha. And on the top, shown CD8s, on the bottom, show CD4s. There's really not much activity. Now, when we take these cells out, all what I do is wash off what we call the cell-free fluid, the cytokine milieu in which these cells are, and I do the identical stimulation. You can immediately see that these cells are making beautiful IL-2, Not much IL-10, beautiful gamma, and of course TNF-alpha that is again critical for macrophage polarization and stimulation. And even more importantly, these cells would be classified as polyfunctional because the same cell is capable of making IL-2 and interferon gamma. So these T cells, pleural T cells, can secrete effector cytokines, supporting the notion that pleural T cells are primed, but they are disabled by the suppressive local environment. So what I have alluded so far is that pleural carcinomas, most of them have already undergone EMT. So this is a disease that will not be targetable with, let's say, CAR-Ts directed toward EpCAM, the surface epithelial cell molecule. The mesothelial cells, the pleural macrophages, and also the tumor itself secrete EMT-promoting growth factors and mediators, amplifying this pro-tumoral wound healing-like environment. Of course, the TEMs are polarized toward wound healing. And most importantly, though, the pleural T cells are plentiful, they are effective memory, but they are really not responsive. So one of the questions is, well, perhaps these T cells are killed by the expression of immune check molecules. Immune check molecules have been well described in infectious disease and immune responses because they're molecules that govern the duration and the amplitude of an immune response. In cancer, these molecules have been probably the most successful new antibody-based immunotherapy. First targeting the PD-1 pathway and second targeting CTLA-4 by ipilimumab. And what you can see that here we are looking again on the top CD8, on the bottom CD4, looking at the various immune checkpoints, and there is a incredible redundancy in immune checkpoints. When you search your literature, you can see that there is 20, 30 different immune checkpoints. Pleural T cells are not really exhausted. Further, when we resort to assays that probably most of you don't know, but certainly the more distinguished members of this panel will know, such as chromium release cytotoxicity, or in our case, we use lactate dehydrogenase-based cytotoxicity. Again, when these cells are removed from their environment, they are spectacular killers. Within 4 hours, they basically ablate all autologous tumor, but they spare adherent non-tumor targets. They are effector memory phenotype, and this in vitro cytotoxic ability of these expanded pleural T cells is highly reproducible between various cancers, but also between various ages of patients. And what you can see here that they also are loaded. This is perforin versus granzyme B. And you can see that they are beautifully activated, 4-1BB or CD137. It's a marker of durable activation. So are pleural T cells suppressed by the local environment in vivo? So what we did, we used a 42-plex, and now it's more like 63-plex Luminex technology that measures the secretome of the pleural fluid. Here I'm comparing normal pleural fluid that we obtained from transaortic valve replacements. In these cases, these patients are age-matched to all cancer patients, but they're getting a new valve. So there's no effusate to benign pleural effusions to malignant pleural effusions. And what you can see, this graph is organized based on the normal pleural fluid. Based on the normal pleural fluid, because that just visually allows us immediately to determine which cytokines or chemokines are either upregulated or missing. And again, just as Jean-Francois alluded, in malignant and benign pleural fluid, These liquids are dominated by nanogram quantities. This is a log scale of IL-6 receptor alpha, IL-6, CCL2, CXCL10, TGF-beta, GROW, IL-8, and VEGF. And you can see the big dip. FGF2, that is a mesothelial maintenance factor, it's actually absent. So this is probably one of the key factors that drives this the fluid accumulation. So just to quickly summarize, pleural secretome is dominated by immunosuppressive, wound healing, and EMT promoting cytokines and chemokines. These are completely absent or significantly diminished in non-effusate pleural fluid. The pleural T cells are neither exhausted nor dysfunctional, but are suppressed by this incredible soup of cytokines and by the local tumor-associated or pleural macrophages. However, they are spectacular, highly cytotoxic killers against autologous tumor. And on Saturday, I will be focusing my talk specifically on the effects of blocking anti-IL-6 receptor alpha to reverse not just the tumor EMT, but also reversing this suppression of inhibitor of effector responses. So what do we propose to do that? Well, we propose to condition the pleural environment as well as targeting the tumor itself to drive systemic anti-tumor immunity. The environment is very inhospitable to immune effector responses, and that also goes with why it's a sanctuary site for tumor. Some of the patients, especially patients with non-small cell lung cancer, are now given immune checkpoints when they have pleural effusions, but the pleural effusions do not get resolved. As I alluded, there are multiple redundant mechanisms to enforce immune suppression and tumor growth. The immune milieu of MPEs is remarkably consistent with respect to this inflammatory wound healing-like environment. And we propose that conditioning of the environment is critical to increase the chances of success of any immuno-oncology, whether it's CAR-T, whether it's adaptive cellular therapy, or whether it's antibody-based therapies. We will have to do something about this environment. And luckily for the pleura and the peritoneum, the local delivery of combination antibody therapy and cellular therapy to the pleural space also has the potential to reduce systemic toxicities, because antibody-based therapies, antibodies in comparison to small molecules, are very large. They do not partition the same way as drugs that are very, very small. And this is why, going back to Jean-Francois, understanding the mathematical models of antibody drug distribution disposition will be critical to success in this area. And this is in your abstract. But what do we need to drive systemic anti-tumor immunity? When obviously we have to turn tumors hot by increasing the tumor-associated antigen presentation. We need to maintain this Th1 immunostimulatory environment. We must support effector T cells, any anti-PD therapy or anti-CTLA therapy. And we argue that we have to condition this intracavitary environment to keep the pleural tumors, I would call, warm, to drive persistent systemic anti-tumor immunity, not just to elicit them and then go away. And this is why probably CAR T-cell infusions shouldn't be a one-time deal. Yes, it's an expensive therapy, but perhaps we should find better and cheaper ways to manufacture these cells per patient and have different dosing schedules for administration. And of course, for me, when you have a tunnel catheter, it's not a one-way street. You can it provides this unparalleled opportunity for local administration of protein and cellular therapeutics, but also for monitoring and understanding what happens when you put these cells in. So thank you. And as everyone else, I and Dieter are from the times when we had Russian in school. I'm originally from Prague, Czech Republic. So I would say большое спасибо. And понимаю немножко по-русски. So be careful when you speak about us. Thank you very much.
Any comment? Actually, my comment, have you tried the therapy and is it improving patients' lives?
To date, we have tried this therapy in urine xenograft models, where we reconstitute the animal with pleural T cells as well as autologous to the T cells, patient tumor. And it is spectacular because it doesn't just block tumor formation, it resolves already established tumors and it prevents recurrence. So when we do second inoculation, the T cells are still there, but probably the best thing about this is that pleural T cells are not just naive T cells that will call GVHD. When you're putting immune cells, human immune cells, into a mouse, the first thing what came to mind, all you mice will die with awful GVHD. They will lose their hair and it's going to be a terrible, unpleasant death. And we have not seen that. In about 250 animals, we only had one animal with GVHD. So we think that these cells, pleural T cells, are pre-selected effector memory cells. So thank you for the question.
So
Just a comment and
a short one, because we need 5 minutes for
yeah,
relaxation. Yes.
just a quick comment. When you use monoclonal antibodies, only 10% of the monoclonal antibodies, when you use systematically, go to the lung. You need to have an higher concentration, and the local situation is very important. We have just an old story, case report in plasma cell leukemia with pleural effusion. We instillate anti-L6, it was in early 90s, and we obtain disappearance of the pleural effusion just by using locally anti-L6.
Yeah, absolutely. And I'm a clinical pharmacologist by training, and I cannot underscore what Dr. C just said, that we need to be thinking about these as compartments, and these ones are protein molecules. So we cannot assume if you pump it IV, that what you put IV is going to make it to the pleura. And we have the same. We've been following now the patients who are given immune checkpoints. We have the plasma, we see what's in the pleura, and only minuscule amount of what you put in is going to end up in this compartment. But that's why, intrapleural or even intraperitoneal administration is extremely exciting. And there are 2 German papers by RUF from the early 2000s that address the PK/PD problem.
It's for that in COVID-19 situation, the usage of this monoclonal antibodies, tocilizumab and ciltuximab, was not efficient because of the concentration. Only 0.3% of the monoclonal antibody is in the bronchoalveolar lavage. It's crazy situation.
This happens when you have clinicians around. You see, they won't stop.